Thanks for the introduction. This will be a nice continuation of the last topic below the diaphragm. I have no relevant disclosures. So I'll kind of talk a little bit about a very brief review of the different techniques that are commonly used, then talk about some established applications and some evolving applications. There's some overlap with applications above the diaphragm, but I think this will be a little bit different in the approach. This is the common techniques. We've heard about all of these. One of the nice components about MR angiography is its flexibility, its inherent flexibility. You can use non-contrast techniques, which I'm not going to really address here, but I think are pretty mature for evaluating the abdominal aorta and arguably its branches. I'm sure you'll hear about some of that from speakers later this afternoon. But you have the ability to use time-resolved imaging, high-resolution conventional first-pass imaging. You can acquire multiple phases. You can image in the pseudo-steady state with a non-blood pool contrast agent. You could use a blood pool contrast agent for both first-pass and steady-state imaging. And as one of the speakers earlier showed, there's strategies of bypassing the whole subtracted MRA approach and using a Dixon method without subtraction. So lots of options available. You can have one or two acquisitions with and without contrast and move on, or spend a lot of time adding things on to your exams. Just a couple examples here. A time-resolved image on the right, which catches the upper abdominal aorta, but shows the contrast come in, as well as a conventional timed first-pass MR angiogram acquired during the first pass of contrast enhancement on the left. Shows very nicely the branches and the size of the abdominal aorta. And these are really state-of-the-art techniques available on every platform. Subtraction is necessary, as you heard from folks earlier. Why is that? In the calf space, as Giles showed, you really do need to have a subtracted method to see the branches. You can still see the branches here without subtraction, simply because the techs have positioned the slabs to not include the bones, right? So you have a narrow slab in the AP dimension, and so the unsubtracted MIP looks okay. But I think we'd all agree it's a little bit easier to look at the subtracted MIP here rather than the unsubtracted MIP. You can take some of the same techniques that the last speaker showed to look at the thoracic aorta and use them in the abdominal aorta. I just have two examples here, different pulse sequences. Both of these are acquired after the first pass contrast-enhanced MR angiograms. This is a pseudo-steady state with a non-blood pool contrast agent. And acquired in this fashion, in this time window, you can still capture all the arteries in the veins. This is a nice salvage technique when there's an issue with timing, as we saw earlier with some of the examples of a mistimed early MR angiogram with capture of the central lines of K-space before the peak arterial arrival of the contrast. This is one of the salvage techniques you can use. You can also, of course, fall back on non-contrast techniques, though. Of the two, I prefer the SSFP approach for 1.5 Tesla, and the GRE approach works a little bit better at 3 Tesla. Subtraction, and using methods that don't require subtraction, so a 2-point Dixon method, MR angiogram. The nice part about this, as was shown earlier for lower extremity MR angiography, you don't need to have the mask, right? So patients don't always take a breath in, blow the air out, and stop breathing at the same spot. Most institutions, including the Mayo Clinic, allows patients to take a deep breath in and hold it, and that's effort dependent. And so they may or may not do the same breath hold for the subsequent contrast-enhanced angiogram. So methods like this are nice to alleviate issues that can arise from subtraction artifacts. You can see image A here with the arrow. There's an apparent stenosis in the right renal artery, which turns out to simply be a subtraction artifact. You can get around this by not looking at the MIP, instead reading off the partition data. But if you just looked at the MIP, I think this could be pretty confusing. So what about applications, established applications, and when to use MR angiography in the abdominal aorta? Well, the reality is CT is a major competitor, right? Arguably, from all of the guidelines we have, CT and MR angiography are rated similarly as usually appropriate for non-traumatic aortic disease, as well as AAA follow-up, so patients who have not undergone repair but are being reassessed to evaluate the size of the aorta and any growth. And similarly for intervention planning, so you have somebody who's reached a AAA size threshold and they're going to perhaps have an open or an EVAR approach. CTA and MRA are rated as usually appropriate again from the ACR appropriateness criteria. And then even after follow-up, so after they've had repair, either open or EVAR, following them up to see if there's any complications from that, assessing the size of the sac. Similarly, CTA and MRA are rated similarly appropriate. So the challenge here is, when would you use one or the other? Is there an advantage potentially with MR angiography over CT angiography in specific settings? something to consider, and we'll talk about that in a little bit. Just some clinical examples. This shows a normal abdominal aorta, but what I like about it is it shows a trifurcation of the left hepatic artery. We talked a little bit about spatial resolution and what's achievable with MR angiography. You can see distal branch vessels and whether or not they're normal or abnormal. I think seeing stenoses in these vessels is challenging. It's difficult to appreciate whether or not these are just tortuous vessels or stenoses because of the MIP technique. But on the partition data, you can see it's just that the vessel's a little tortuous out there. Obstructive vascular disease, just an example of somebody who's had an infrarenal abdominal aortic aneurysm repaired with a bifurcated graft and also has severe bilateral renal artery stenoses. You can see that well in the MR. This is a patient with a bypass graft from the abdominal aorta here all the way up to the common hepatic artery, and somebody who's undergone a liver transplant with a complex reconstruction. You can see a stenosis right here. Oh, I'm talking to myself, aren't I? There we go. You can see a stenosis right here at the anastomosis that was confirmed with Doppler ultrasound. The patient underwent stenting in IR. This is going to be addressed later on by another speaker, but what I like about this example is I have really nicely zoomed in DSA images showing a similar configuration of the beaded stenoses associated with FMD in this patient with right renal involvement. And so I think one of the knocks against MR angiography, we've talked about this a little bit earlier in terms of the spatial resolution, is it's inferior to CT, but it doesn't suffer from calcifications impacting the image quality and the appearance. And so if you have somebody who's really kind of there between ages, you suspect it's going to be FMD, but they probably have some degree of underlying atherosclerosis. Perhaps MR is a better choice in that setting because you don't have to worry about the artifact from the calcification. I like this example simply because of the time-resolved imaging allowing you to really see the characteristics of filling of this massive renal AVM. Imaging these patients with first-pass MR angiography is possible, but it's challenging because of the overlapping arterial and venous structures. This is like an extreme version of shunting in the calves that Giles talked about earlier. It's best to do this with a time-resolved technique, in my opinion. And this is similarly what was seen at angiography. And after coil embolization, you can't really appreciate how many coils are in here. There's some snickering out there, but this is actually 2 guide wires in addition to about 15 Nestor coils. So half a Mercedes is stuffed in there to block that up, but it was successful. Another example of the pseudo steady state imaging that I talked about before. So the nice thing about imaging patients in a pseudo steady state, so it's between phases. It's best done with a blood pool contrast agent. So if you happen to have Ferraheme or Ferumoxytol on formulary, this can be done with true steady state imaging. But if you don't have such an agent, you can do your first pass SMRA, and then while the contrast is being excreted, you can do these higher resolution images that shows you both the arteries and the veins. And the previous speaker showed a nice way to highlight just the arteries through this process by doing subtraction. But in general, when you're looking in the abdomen, the abdominal aorta is large enough and thrown off at least the IVC enough, you don't really need to subtract them to separate out the vessels. You can see both quite nicely. And so what I like about this is it shows some plaque here along the right common femoral artery, and it shows also the relationship of the IVC and the branches of the iliac arteries. And it's a useful test in patients who are suspected of having May Thurner to evaluate the compression and the relationship of the vessels in the pelvis. Large vessel vasculitis, the last speaker showed a few examples of this, but I think MR angiography is well suited for this application. In the practice at Mayo Clinic, a lot of these patients are sent through CT angiography, and I find that difficult to distinguish atherosclerosis that's somewhat active from large vessel vasculitis. MR, on the other hand, allows you to see the wall thickness very nicely. You can use dark blood imaging for that, but I find most helpful the 1 minute and 5 minute post-contrast T1 weighted imaging just to see if there's any enhancement of the wall or enhancement of the wall thickening here involving the SMA. And in this patient who has wall thickening and evidence of remote large vessel vasculitis, there's no evidence of ongoing inflammation on MR angiography. At my last institution, we did a fair amount of PET MR with this application. This is a great, I think, use of MR angiography along with molecular imaging to carefully look at such an application. So you have the dark blood T1 weighted TSE sequence here, which shows you in 3 dimensions the wall thickness and areas of abnormal wall thickening very nicely. So this doesn't limit you to slices that are typically applied for this application, but instead lets you look at the entire thoracic, and you can apply this to the lower abdominal aorta as well. And this patient has evidence of active vasculitis, so there's enhancement involving the entirety of the thoracic aorta here, as well as the abdominal aorta. And this shows up nicely on the FDG image, where you can see brighter molecular signal indicating higher avidity within the abdominal aorta, indicating that's a more active area of involvement. This is a Ferumoxytol enhanced MR angiogram from a colleague at Mayo Clinic, Pat Murgo, down in Florida. And their practice has been using Ferumoxytol enhanced MRA for several years, and it's part of their armamentarium in patients who have renal failure or otherwise can't receive gadolinium-based contrast. The advantage over non-contrast approaches for aneurysms like this is that you can do all the same aneurysm planning that you can with a CT study with MR. The challenge is that you don't have the calcifications that you would easily see with CT, and that can be brought into play by doing fused imaging, and I have a couple examples of that from Paul Finn. This is just playing the actual movie showing the partition data and the very angulated proximal neck of this infrarenal abdominal aortic aneurysm. In terms of AAAs and their follow-up, endoleaks are very well seen with contrast-enhanced MR, and perhaps the knock against them is they're overly sensitive. I mean, when we talk about overly sensitive, we want to see these things, and if they're present and the sac is similar or smaller in size, I think that's a good thing. But in general, they are more sensitive than CT. They're more sensitive, though, for smaller cellular leaks that are often not clinically relevant. So I think the usual practice is to follow patients who have undergone EVAR with CT angiography, maybe non-con alone, see the sac size. If the sac is increasing, that's when you really look for the endoleak. And in that setting, if a negative CTA occurs, or if your practice is to consider MR, it's a great tool. It's more sensitive for detecting endoleaks, and it's extremely helpful in evaluating patients you suspect of having endotension. So this is multiple T1-weighted fat side images after contrast. You can slowly see this fill-in of this type 2 endoleak in the symptomatic patient. And this is another series that the authors use time-resolved MR angiography, which is really my preferred approach with this. And you carry out the acquisition far enough to see the leak. And in this case, there's a leak at the distal seal zone of the iliac limb of the graft. And in this cohort, they had 31 patients. 30 to 31 patients were correctly classified in terms of which type of endoleak there was. And in one patient, they misclassified a type 2 endoleak as a type 3 endoleak. So it's a great application for MR angiography. I have a couple of slides, from Paul Finn, highlighting the utility of MRA for TAVI, vascular access planning. The last author showed some applications of this up in the chest, but just leaving the annulus alone right now, just dealing with the peripheral access vessels. This is a nice technique. Many patients who are being considered candidates for TAVI do have some degree of renal insufficiency, and so this is a way to save that iodinated contrast for the catheters, for the actual TAVI procedure if they need to confirm their location prior to placement of the valve. What you can do is combine haste imaging. I have to keep remembering that I'm not synced here. So haste imaging on the left with the contrast-enhanced MRA on the right. And this allows you to segment out the size of the sac and generate volume-rated images of the thoracoabdominal aorta. You can also see the iliac vessels very nicely with this. And it's also extremely useful for aneurysm surgery planning as well. So you can size the entire aneurysm sac, you can evaluate how much thrombus there is, you can see the bifurcation, assess the relationship of the neck to the renal arteries, and do all the same measurements you could for an endovascular aneurysm repair, just like you could evaluate the iliacs for sizing prior to placement of your sheath for TAVI. The calcifications seen on this image come from a non-contrast CT that is then fused with the MRA data, and that's how you're able to put the two together to understand what the calcifications are for access planning. You can size the vessel very nicely with this technique. You can see the sac very well, including the patent lumen. A couple of authors have looked at bringing MR angiographic images into the IR suite for planning endovascular procedures. This is a small series from a group in, I want to say, Germany that did this study. They took contrast-enhanced MRA data and they fused it with on-table cone beam data. And they're able to use the contrast-enhanced MR to guide their procedure. This arrow shows an area of stenosis in this patient distal to a left iliac endograft. And so you can see these guide wires that come up here. This is an overlay image with the MR aligned to their cone beam CT. And then they use this to position their balloon and do a balloon angioplasty followed by stent placement. And this is their post-stent image. So they're able to use the MR for guidance during the case and avoid extra contrast exposure for iliac angioplasty. Just comparing the pre and the post image. You can see the arrow there on the left showing what it looked like prior to the intervention. In just the last minute here, just to finish up, the last speaker talked about dissection. And what I really like about time-resolved imaging is it does give you some sense. It's a poor man's sense of the flow in the dissection. Most thoracic dissections will extend into the abdominal aorta, and often it's the abdominal aortic impact that causes problems for patients with malperfusion. This is a case from Mayo Clinic that shows a repaired type A dissection with a residual dissection down in the abdominal aorta that's causing some flow problems. And if I get this movie to play, I'm going to see if I can slow it down a little bit here. So there's a flap that extends, as you can see here, through the segment of the abdominal aorta where the mesenteric arteries and the renals come off. And there's a very tiny fenestration below that supplies flow retrograde. And that's better seen, I think, on the 4D flow image. So there's forward flow into the dissected segment here. There's retrograde flow into the dissected segment here. And there's renal arterial flow coming off the false lumen that's maintaining the patency of this segment. And getting that information, I think, from CT is challenging. And the last thing I'll just mention is evaluating aortic function is possible now, combining different techniques. This is a paper from Northwestern, combining MRE-derived wall stiffness along with 4D flow-derived wall shear stress to assess aortic function in healthy subjects and evaluate changes with aging as unique early biomarkers for aortic disease. So in conclusion, contrast stance MRA has a lot of potential clinical applications. It's, I think, equitable, similar to CT angiography for abdominal aortic applications, but the ability to do unique things, including time-resolved MR angiography, as well as evaluate aortic wall function and assess vasculitis, I think makes it win the day. So thanks for your attention.